So, good morning, everyone. I am Dr. S. Narasingan, Vice Chairman of the Lipid Association of India, and I am also the Vice President of the World Hypertension League. I have been given an opportunity to conduct the International Congress on Hypertension, which is going to take place in India for the first time and then in Chennai next year, in February 21st to 23rd. And I am delighted to take part in this particular Congress, which is on Lipid Association of India, conducting it as a national congress at Pune under the guidance of Vijayan. And I am really thrilled to give a talk here on hypertension and dyslipidemia. The prevalence of hypertension is increasing globally. It has been projected by WHO that the alarming figures not only encountered globally, but that too in India it is high on the higher side. More than 31% of people are suffering from hypertension in our country. And not only the morbidity but also the mortality is important as far as hypertension is concerned, because it can precipitate stroke, it can precipitate heart attack, it can end up with the problem of heart failure, it can precipitate aortic dissection, peripheral arterial disease, atrial fibrillation. But the clinicians should not forget about one important complication of hypertension, that is dementia, which need to be considered not only in elderly population with uncontrolled hypertension, but also in those people in whom you have a middle-aged person with uncontrolled hypertension. You need to think about the dementia. Ladies and gentlemen who are watching this particular video should remember that hypertension is an important condition which can be prevented easily, and if it is not detected early and if it is not controlled properly, probably that may even lead to death. The mortality rate as far as hypertension is concerned is on the rise globally. Nearly about 10 million people die due to uncontrolled hypertension globally. I think we had lost about 2 million people during the COVID period of 2 years, but surprising to see we are losing nearly 10 million people due to uncontrolled hypertension globally. This is giving you the magnitude of the problem that all of us are encountering globally. The important problem is hypertension is always associated with other conditions like diabetes or dyslipidemia. I need to tell you that many people with hypertension have dyslipidemia, they have overweight or obese, they also have a concomitant problem like diabetes. You take people with diabetes, they also have concomitant problem, hypertension, dyslipidemia or overweight. You take people with dyslipidemia, significant percentage of them have hypertension or dyslipidemia or overweight or obese. So that means there is a central role played by the obesity or the overweight, which push these patients for the conglomeration of all these risk factors to come into play to increase the cardiovascular risk, at the same time increasing the mortality globally. I think we need to consider this combination of hypertension and dyslipidemia in every patient who walks into the clinic. If you seek advice for only hypertension, don't look at it as an isolation. Try to think about the problems associated with it, including dyslipidemia. The prevalence of dyslipidemia with hypertension is 15 to 30% in population-based studies. This is called as lipid tension, or otherwise called dyslipidemic hypertension. One need to think about controlling both dyslipidemia and hypertension. In fact, there are a good number of studies which had gone to prove that treating these two conditions concomitantly will reduce the cardiovascular risk and mortality. This one study, which was considered as the most important study in the field of hypertension, very new study, more than 40,000 participants, which was considered as Ascot Study, where they treated patients with hypertension with the three major drugs. They came out with the finding that all three drugs are good to control the hypertension uniformly, but the risk of reduction of cardiovascular risk was not identified between all these three drugs, almost equal. But majority of them had shown a response to the diuretic, thereby proving that the diuretic should find a place in the management of hypertension. That was probably considered as a valid document or a valid information by the ACCHA, which endorsed this opinion of informing the societies that hypertension should be treated with the diuretics first. In fact, there is yet another study which attracted our attention, is the Ascot Study, BPLA study, where they have introduced these drugs, amlodipine plus perindopril or minus perindopril, on one arm, and the other arm is atenolol with the benzofluorethiazide plus or minus. These people were followed up. There was an insignificant reduction in the cardiovascular risk, about 10%, but the secondary endpoints were coming down considerably in this study. What these investigators did in Ascot Study, they took out nearly about 10,000 patients and then they treated on them. One arm received only the atorvastatin 10 milligram compared with the placebo. Final conclusion is that 36% reduction in those people who received a concomitant therapy of statin along with the antihypertensive drugs. Even a long-term follow-up of the Ascot Study, 16 years follow-up, had completely shown the benefits of reduction of not only the blood pressure but also the lipids in those patients with the baseline cardiovascular disease. Nothing but associated cardiovascular risk factors in Ascot Study was very high in participants, thereby showing that there is a valid information from Ascot Study to treat simultaneously hypertension and dyslipidemia. HOPE study again revealed the same problem, that treating dyslipidemia is much more important than only controlling the blood pressure. Controlling both probably will pave the way for these individuals to bring down the cardiovascular risk. Yet another study is called TNT study. The study is actually where they were using only 10 milligram of atorvastatin for chronic stable angina. They increased the dose to 80 milligram, wanted to see how much is the benefit by using the statin of high dose for chronic stable angina patients. It clearly revealed that about 25% reduction in people with diabetes, 26% non-diabetic in TNT study. But what was important in conjunction with the hypertension, that dyslipidemic patient, those people in whom you have a low tertile of LDL cholesterol and a reduction of blood pressure of less than 140 systolic, has shown a maximum reduction of 42% compared to those people who are keeping their levels more than 140, 90, at the same time the LDL levels were more than 70 milligrams. That again emphasizes the fact that you need to treat both the conditions simultaneously to get the maximum benefit of cardiovascular risk reduction. I think having got this sort of evidence-based approach in managing both the conditions, I think I need to emphasize that we need to treat patients with hypertension and diabetes, hypertension with dyslipidemia, hypertension, diabetes, dyslipidemia. Vigorously, aggressively you should control by not only controlling the blood pressure but also controlling the statin. Do we have a study to show that all three drugs or two drugs can be combined and can be given for a patient? The recent study is the CORAL study, where they used a fixed combination of atorvastatin plus perindopril plus amlodipine in those patients in whom there was no problem at all, and these patients were followed up. There was a reduction of blood pressure, systolic, diastolic. In addition, there was also a response to the LDL cholesterol reduction considerably, showing that there is a concomitant approach to reduce both the conditions will reduce the cardiovascular risk in the long run. That's the message what we derived from CORAL study. So at this stage, we have enough data to show that we need to concentrate on both these risk factors simultaneously to bring down the atherosclerotic cardiovascular risk. This benefit should be given to all our patients to make them live for a long, long period. Thank you very much, ladies and gentlemen, for listening to this small video. Yeah, if you like it, you can share it. Of course, you can subscribe it also for live TV.